Good afternoon. Thank you for the GIS leadership and the chair of this session for this opportunity. So the topic of my presentation is cardiogenic shock, where Impella worked, and what the data behind it. Obviously, as we know, cardiogenic shock is a syndrome with a broad spectrum. So anytime we talk about cardiogenic shock, we need to make sure that we are on the same page and we're talking about the same patients because of the variety of the patients that are embedded in this category. I think the best reference would be the cardiogenic shock classification expert consensus statement from SCAI, which was published and then revamped 2 years later. And as you know, the cardiogenic shock is classified from A to E, and A is the patients who are at risk, and E, those who are an extremist. Probably most of the patients that we see are in the B and C categories, and some of those quite a bit often deteriorate to the point of having worse outcome if we do not do the right intervention at the right time. In addition to SCI shock classification, the cardiogenic shock working group headed by Dr. Kapoor, they have added significant granularity to the data of the cardiogenic shock and how to classify this because the treatment would vary depending on what the stages they are. I think as a part of showing the Impella, I want us to agree on three simple facts. And the first facts that we all know is that the acute MI cardiogenic shock mortality remains significantly high and, to be honest, unacceptable in 2023, ranging from 40 to 50% depending on the database that we look at. These are patients from cardiogenic shock working group. Depending on what the cardiogenic shock reason is, either heart failure or acute MI, the mortality rate varies from 40 to 50%, as I alluded earlier. So I'm going to start with a clinical case which goes to why I think Impella work, what is the data, and where we go from here. This is a 36-year-old woman. As you see, despite her young age, she has significant ischemic risk factors. She also has a hypercoagulable condition with factor V Leiden mutation, prior DVT and PE. She had had a remote inferior-posterior MI with emergent PCI of left circumflex. 2-3 years later, she had a PCI of LAD when she presented with non-ST elevation MI. So this presentation is 2 weeks after presentation with non-STEMI and PCI of LAD. You see this is the baseline ECG, and this is the ECG that she presented with to hospital with chest pain, abdominal pain, and variety of symptoms. You see her hemodynamics. Her blood pressure is borderline. She's tachycardic and tachypneic. This is the angiographic findings. This was done somewhere else, but you see a femoral axis, a left dominant system, and a patent left circumflex stent. Obviously, totally occluded the stent in the proximal LAD. According to the CAT report at the time from the outside institution, she had CAT and PCI with repeat drug-eluting stent placement. So obviously her symptom got better. You see her hemodynamic, blood pressure 90 to 100 systolic, heart rate of 110 to 120 with good oxygen saturation. So the question in the mind of the operator was, what should we now? Should we do a balloon pump, nothing, intubate and mechanical circulatory support, or pat yourself on the back and say, great, we got great results, let's go home. According to the report, the patient thought to need a mechanical circulatory support. They decided to put an intra-aortic balloon pump, and because they were concerned about her body size and risk of vascular access site complication, this is one of the items that always come up when you think about mechanical circulatory support and what is the vascular access site issues. So the first fact was acute MI mortality is high. The second fact that we need to agree on, that at least the way it was conducted, and I'm sure we can dice the data or how it was done, but the way it was conducted, the intra-IAPP shock 2 trial indicated that there is no benefit of balloon pump support in the setting of cardiogenic shock, both short-term data and long-term data. And of course, because of that, the indication for using intra-aortic balloon pump, as you know, it was downgraded both in US and European guidelines. Not necessarily related to this case, the third piece of fact is that multi-vessel PCI, at least the way it's done now, with that appropriate mechanical circulatory support, does not seem to improve the outcome in patients with cardiogenic shock, with either higher mortality, renal replacement therapy, and long-term is a wash. Same thing, this indication obviously got downgraded. So what is the data in supporting using mechanical circulatory support, in particular Impella? Obviously, you see data from NCCI, the National Cardiogenic Shock Initiative, that they achieved survival rate of up to 70% by using dedicated shock protocol, which is now customary in most of the US hospitals, including where I trained and where my colleagues trained. And if there are several of registry, well-run registry data, obviously, I'm sure many of you might raise your hands and say, well, this is not randomized data. And we all acknowledge that this is not randomized data. But as it comes to registry, these are well-run prospective registry that have shown across number of hospitals and multiple states that survival rate could be improved from 40 to 50% to 70 to 80% using dedicated shock protocol. This is an overview of National Cardiogenic Shock protocol. Rather than using the so-called door-to-balloon time, is door-to-support or door-to-unloading. Utilization of right heart catheterization is mandatory in these patients, maybe not at the beginning, but once you put the Impella and do the PCI, then right heart hemodynamic become very essential. Calculating your cardiac power output using mean arterial pressure and cardiac output, as well as using PAPI assessment in case of right heart involvement. So back to the clinical case. This patient was initially transferred to CCU with a balloon pump. Unfortunately, this patient required a escalating dose of his active support, then developed further hypotension, further tachycardia, and sign of hypoperfusion. You see her lactate level rising from 3 to 4.5 to 6.4. At this time, fortunately, the operators and the caregivers got together and decided to transfer the patient to the shock center. These are the initial hemodynamics of the patient on arrival. You see significant elevation of filling pressures, cardiac power output of 0.55. As a reference, anything less than 0.6 or ideally less than 0.8 is associated with significantly bad outcome. Patient had totally fine access for placement of Impella. She had the placement of Impella CP, as you see. Over the next 24 to 72 hours, her cardiac power output improved, filling pressure improved, her lactate gradually went from 6.5 to 1.7. She was weaned off of inotropic support, and Impella was removed. Her EF was 45%. One thing that we know, inotrope are not good. The higher the inotrope used, the higher the risk of adverse outcome. One thing is for sure that we need more randomized data. This is an overview of all the, not all, some of the shock trial, whether it's pharmacologic, whether it's device trial, that we definitely need more randomized trial. And in that regard, the RECOVER 4 trial is currently evaluating those patients and usually looking at class C2E cardiogenic shock patients. I need to plug in the Emirate Cardiogenic Shock Initiative that with the leadership of Emirate Cardiac Society and Professor Shahab, and we obviously there is this GIS is going to be the first time the Emirate Cardiogenic Shock meeting will take place. and we hope that it will definitely expand the knowledge base and the services for cardiogenic shock in the region. Thank you.